All right, everybody, thank you for joining us for another week of grant rounds. As usual, the hospital's in church red, so we appreciate you taking the time to join us for some education. Today, we have the pleasure of introducing our very own Dr. Erin Gabriel today, and she's here today to update us on some pre-op medicine. So,
Pre-op stuff.
Pre-op stuff.
It is a little bit of a hodgepodge of pre-op stuff, but hopefully it'll be helpful.
We should actually, before we start,
Yeah.
Avina and Alex Tanko, one of our PAs, found out that in GP2, Alex did,
All out.
but there is a way to print the ABS in GP2 without printing all of the other stuff beforehand, so it's just like a medication summary. So if you're down there in the next few weeks, just check in with the PAs, make sure they're doing that. It's a safe thing for safe patients and all the great scripts. Anyway, all right, sorry. Go ahead.
That is exciting. Seriously, we waste like a lot of paper done. I don't know if you have any others this week, but yesterday was Maria's birthday. We're wishing her a happy birthday.
Thank you.
And I appreciate everybody coming, although I know like 50% of you at least are just here for the Thai food. Okay, so we're going to talk about like a few sort of seemingly random topics in pre-op medicine, but some like kind of article reviews and just some sort of more general sort of education. And I just wanted to talk about some things that we don't talk about a lot because I know everybody kind of comes to the boot camp every year and we all sort of get updates or you guys help with education for the health staff and we really talk a lot about like the core pre-op topics, but we don't really have a good forum where we kind of branch out and talk about sort of like newer things or other things that are kind of like outside of that core of what we do sort of every day. So we're just going to jump right into an article that came out last year, sort of based on the POISE-2 data, looking at the effect of aspirin continuation or initiation in a subset of patients from the POISE-2 trial, just in the going for vascular surgery. So yeah, I'm looking just to see if there's a subgroup effect of initiating or continuing aspirin just in the vascular surgery patients. So again, POISE-2, there's a lot of articles coming out, from that data set, but it was over 10,000 patients. And the subgroup analysis actually only included 600 vascular patients, so it's a pretty small subgroup of this very large data set. The primary outcomes they looked at were death or MI at 30 days. Secondary outcomes were vascular complications, like amputation, peripheral arterial thrombosis, and major bleeding. So they excluded even more patients from that group with who were going for carotid endarterectomy because aspirin has already been shown to be beneficial in that group, so those patients were not included. And then of the remaining about 600, they were about evenly split between patients going for aneurysm surgery versus surgery for occlusive disease. So basically the results showed that periop aspirin initiation resulted in no benefit. Withdrawal of patients who had been on chronic aspirin and switching to the placebo group did not increase cardiovascular or vascular complications. Again, limitations is a very small number of vascular patients, but we can kind of pretty safely conclude that overall the POISE-2 results still, can sort of be extrapolated to the vascular patients. So patients who are on aspirin for secondary prevention, even if they're going for vascular surgery, in theory, we can hold it. I know in general for our practice here with our vascular surgeons, we generally do what the vascular surgeons want for these patients, but if it ever comes up and, there is some evidence that it's okay to hold the aspirin, especially if we can go to high PDS. Any questions about that one? All right, now we're going to talk about ACE inhibitors. So I know, again, this is kind of one of those things where it's like an interesting article, but we already sort of have our practice where we, generally hold ACE inhibitors, but, again, there's some conflicting evidence in the literature. Some of the literature is not that robust for non-cardiac surgery patients, in general, like non-vascular surgery patients. So this particular article looked, was out of just one hospital in a relatively small group of patients, but it is interesting. So, like I said, we have some good evidence that RAS inhibitors are associated with intraop hypotension, specifically for cardiac and vascular surgery patients. Intra-op hypotension is associated with an increased rate of mortality, and the duration of intra-op hypotension is associated with increased end-organ damage. So the longer you're hypotensive, obviously, the more at risk you are for end-organ dysfunction. So they were looking at what is the effect of continuation versus omission of the final ACE inhibitor dose on hypotension in non-cardiac, non-vascular surgery patients, which is generally what we do. We hold just the last dose right before surgery. So it's a prospective trial, randomized just 290 patients taking ACE inhibitors. They didn't look at ARBs. They had a lot of exclusions, so they excluded thoracic patients, major vascular surgery, transplant surgery, oncology surgery. They looked at patients in their pre-op clinic they excluded patients in their pre-op clinic whose systolic blood pressure was less than 90 at the time of the pre-op visit, or more than 160, or diastolics less than 60, or more than 95. Decompensated heart failure they excluded, patients with a significantly reduced EF, less than 40%, or end-stage renal patients on dialysis. Primary outcome was intra-op hypertension. Systolics less than 80 from the time of induction all through their PACU stay. And secondary outcomes were, or to the point when they got to the PACU, secondary outcomes were post-op hypotension with systolics less than 90 on the floor, and post-op hypertension with systolics greater than 180. They also looked at AKI, MACE, and mortality. So, the blue line here is the ACE inhibitor omission, and the yellow line is ACE inhibitor continuation. So it's kind of what we would expect. The ACE inhibitor continuation group had more hypotension with induction and throughout the entire surgical encounter. So the ACE continuation generally led to more frequent and longer duration of intra-op hypotension, more post-op hypotension, and less post-op hypertension. So none of that is terribly surprising. There was no difference in this study for AKI or major adverse cardiac events. So again, limitations, this was a very small study with less than 300 patients. It was a single institution, and they didn't look at ARBs. So it didn't really kind of answer all of our clinical questions. They excluded a lot of patients, and generally speaking, because it was so small, it was underpowered to really look at those post-op outcomes of AKI, MACE, mortality. Bottom line is, I think this at least lends a little bit of support to what we do, which is holding the ACE inhibitor. It doesn't really help in the questions of like heart failure patients, uncontrolled hypertension. I think a lot of us probably, we've all sort of discussed as a group how sometimes when the patient really comes into the pre-op clinic and their blood pressure is extremely uncontrolled, that, you struggle with that holding of the ACE inhibitor. If their blood pressure is like 180 at the time of the pre-op visit, is this really the right thing to do? And I don't think this study really helps us answer that question because those patients were excluded from this trial. But in general, in conjunction with our anesthesiology colleagues, the general policy is we're still holding ACE inhibitors, even if the blood pressure is really not well controlled at the day of the pre-op visit.
Erin? So I remember years ago the anesthesiologist saying that they just anecdotally were noticing the blood pressure bottoming out very hard to bring up when the patients took their ACE inhibitors. So we've actually made this change a long time ago based on just what they were seeing in the OR. So I'm kind of glad we've been on the front edge of this. That was very helpful. So one question is, it's underpowered for clinical outcomes. Did they describe whether this intra-op hypotension required some intervention, like IV fluids or medication alterations?
They didn't talk about that. Yeah. I mean,
because presumably it has some untoward effect. It's not just a number. Right.
And even, presumably, with these episodes of hypotension, some of these are systolics like going into the high 90s on average. So the anesthesiologists presumably are managing this clinically as appropriate, and even with their management in the OR with fluids or medication, it still remains low. This is, the anesthesiologist management in the OR wasn't measured by the study. So,
one of the anesthesiologists talks about this. He was there because he focused on the kids.
Ryan,
But he said at Sinai, his understanding for the reason they stopped people from doing ACE inhibitors pre-op was because the medication that people were using to bring blood pressure up is really expensive, and they were finding that it's like everybody was reaching for the same medication like over and over again every time this happened. Like every time somebody tried this, like they would mention it. I don't know if that's true.
I don't know if that's really true, but
Like at Sinai, that like they noticed at Sinai
they were using a lot of it because it was so
less.
It's interesting, even if you don't, even if you hold the ACE, your blood pressure drops dramatically.
Yes.
So I guess they're holding other things. I
Um,
wonder why the blood pressure.
right. I mean, this is from the time of induction, so
Yeah,
I mean,
just the anesthesia.
just the anesthesia
Yeah, right.
during induction. So that's when the anesthesiologist notice it the most. It's most dramatic, and I mean, at least anecdotally here, they feel like it's exacerbated when they are on an ACE inhibitor and it becomes refractory and they're not able to bring it up. So I think there's definitely more to come on this. I mean, I think we need like more studies, more randomized trials, but it seems like at least preliminarily we're sort of like on the right track with this and everything. And again, it's sort of the question of like, we know that intra-op hypotension and like prolonged hypotension in the OR is associated with adverse events and and organ damage, and it's just, and now we know that ACE inhibitors are associated with hypotension, so it's just sort of connecting that dot to the next step of being on the ACE inhibitor causing the hypotension actually leads to major adverse events. So we're gonna switch gears and talk about frailty, which is something I don't think we've really ever talked about in the setting of pre-op medicine. But it's an interesting topic, and I think it's being studied more and more in relation to surgical outcomes. If you like Google frailty and surgery, there's like multiple articles coming out, especially in the last like 2 or 3 years. It seems like just in 2018, like multiple articles coming out, and they are really like very surgery specific, like impact on frailty in colorectal surgery, impact on frailty in thoracic surgery, impact on frailty in urologic surgery. So like everybody is sort of looking at this issue. I think frailty is again one of those things where we sort of like know it when we see it. It's very easy for us to sort of eyeball a patient and say we think this patient looks frail. But in general, frailty like has a real definition. It's an age-related, multidimensional state of decreased physiologic reserve. And this decreased physiologic reserve really leads to poor outcomes for patients when they go for surgery. There are many screening tools out there for frailty. Some of them are like very comprehensive, like the comprehensive geriatrics assessment, versus like very quick screening tools that are either can be done like quickly by a physician in the office, or that are more like patient reported, and the patients can actually fill it out just with a simple questionnaire. There's some of them like require very specific measurements, like a time get up and go test, or like hand grip strength to complete the assessment, or some are, like I said, totally patient reported and just sort of like symptoms. And there hasn't really been one that's sort of come to the forefront as like this is the best way to screen for frailty in the pre-op setting. Up to 25 to 40% of older patients undergoing major surgery are considered frail, depending on which study you read. Pre-op frailty is actually associated with like a 2 to 3-fold increase in adverse events for patients. Increased length of stay, increased mortality, increased chance of being discharged to a SNF or a SAR. So we'll talk about a few of these like screening tools, and then we'll talk about an article that compared a couple of them. So the Frail scale is an easy one to do. So F stands for fatigue, just simple, like again, patient reported, are you fatigued? R is resistance, so can you climb a flight of stairs? A is aerobic, can you walk a block? Illnesses, if you have more than 5 general medical illnesses. And loss of weight, so more than 5% weight loss in the last year. So if you get, each one is a point, and if you get a 3 or more, then you're frail. 1 to 2, you're pre-frail, whatever that means, and 0, you're not frail. So then this one is like a pretty easy one. We'll talk about a couple more in a minute. So this was a study that also came out last year in the Annals of Surgery, Frailty as a predictor of death or new disability after surgery. So it's a prospective multi-center cohort study. They looked at 645 patients for over 65 going for major surgery. So they compared the clinical frailty scale and the modified PREOP index, and I'll show you what those are in a minute. The primary outcome they looked at was death or new disability at 90 days post-op. Secondary outcomes were like things I mentioned, like length of stay, rate of institutional discharge, hospital costs, and then they actually looked at the ease of use of these two screening tools as well. So this is the clinical frailty scale. I don't know if anybody can actually read that, but it does come with these nice little pictures of these cute little elderly patients, and someone who's obviously like a 1 is very, very fit, is like actually like jogging a little bit and exercising, down to like the 9 terminally ill, life expectancy less than 6 months, and then everything sort of in between.
I think we're 3.
We're 3? Okay. Managing well. We're managing. I feel like that's how most of us are getting through our days, right? But it gives like nice description of sort of what this is. And this was the one that was much easier in the study for the physicians to do quickly in the office. It's like less than a minute to do. And this is the modified PREOP index, which is another popular one. Similar things to that frail scale that I mentioned. Again, the weight loss, weakness. This one actually you have to measure hand grip strength, which is a major, barrier for doing it like quickly in the office. Again, fatigue or exhaustion, slowness, which is, a strange one, walking speed, which again is like hard to measure, and then low physical activity level. So again, using this other scale, Minnesota Leisure Activity Scale. So it's like some of them are more complicated and build in other assessment tools into the actual frailty assessment. Some of them use like the mini cog as part of the frailty assessment too. So it's like harder to kind of perform in a quick way. So they found no significant difference in the study in the performance between the two tools. Positive screens were associated with increased length of stay, cost, and institutional discharge for both of those tools. And again, the clinical frailty scale is a lot faster and easier to use. So what do we do about this? It's sort of like a little bit of a depressing topic in some ways because, we see these patients, we can easily kind of determine that they're frail using any number of these screening tools, but then, like, so what? I mean, we can say that they have an increased risk of, bad outcome with surgery, but then what are we supposed to do with that? So this was one, I don't know if anybody besides me has heard of SPACLI, but it's like this, basically it's a pre-op assessment, like quality improvement group. But this was like from a kind of a task force that they looked at from like, it was anesthesiologists, geriatrics practitioners, and sort of pre-op experts, and sort of came together and sort of like, what are we going to do with all this frailty data, and how can like, what in sort of best practice, what would we do to implement changes for these patients? So they recommended like actually just implementing frailty screening as like the first step, which is easier said than done depending on where you're practicing. Plus minus doing like a mini cognitive screening for dementia. If somebody was not frail and the cognitive screening was okay, they thought that they put them in a low risk category and that would sort of be usual pre-op care. If they were in the pre-frail or frail category, they would put them in sort of a high risk frailty sort of assessment. And from there, it sort of broke down depending on whether there was like access to geriatrics practitioners or not. But the number one thing there, sort of, up here to the right is, talk to the surgeon. This patient is frail, they're at high risk for not doing well. Like it should be something that the surgeon is aware of. Although I think surgeons are generally aware of this and they don't like to operate on elderly patients unnecessarily. But just keeping the lines of communication open and making sure they understand that it does confer increased risk for their patient. And then we'll talk about sort of these 3 things at the bottom that they talked about, sort of what are the next steps. So they talked about shared decision making. So maybe this should prompt a goals of care discussion with the patient. You might want to advance, involve the PCP and start discussing like big picture, how is this patient doing? Is this surgery really necessary? What are we expecting the benefits for this patient to be? I think, again, with a lot of pre-op, a lot of it is, discussing expectations for the patients as well. Sometimes patients like really think they want a surgery, but if you said like, there's a good chance you're going to end up needing to go to a rehab, or you could end up in a nursing home, or you could end up with like all of these problems, and they might sort of rethink whether or not that's really like a priority for them to get their knee replaced or whatever it is. And it's also a good, in addition to goals of care, to sort of making sure you are thinking about advanced care planning. So make sure they have a healthcare proxy, make sure if they want to live in will, time to discuss these things. The second group here is called prehabilitation. Anybody ever heard of prehab? So that's like, again, like a sort of a hot topic in peri-op medicine, but prehab is like this idea of identifying patients who are not in great shape before surgery and trying to fix that before they go into the OR. So physical exercise programs, nutritional optimization, psychological intervention if needed if the dementia, depression, and other things that might make them more likely to fail. Prehab has been used successfully in or at least in small groups described for patients who are having like surgery for cancer, thoracic surgery, things like that. They have used it for thoracic surgery for preventing like post-op like pulmonary complications with prehab, like to increase their strength for breathing. So basically, just like if you're stronger, you can breathe better, and you're less likely to remember that. And then the third thing they recommend is like geriatrics co-management. So they would like refer them for a comprehensive geriatrics assessment, and they recommended like in-hospital co-management by geriatrics, early mobilization, and discharge.
I think they just, I know it's just a small one.
Yeah. Oh, interesting. So you guys actually actually saw all those patients?
Yeah, but yeah, renal transplant just over the past several years, going for transplant has increased. So we found that pre-assessment to see if it's still advanced
Right.
to have that additional management.
It's an extremely sick group of patients who have been on dialysis for 8 years or whatever, and waiting for the transplant, so that might make sense.
We're hopeful, but it's in certain, and Sir John was that next week, there was someone interested in that, there was a lot of people
I think it's like a really interesting topic. I think that there aren't that many places who have implemented anything nearly this robust, but
Are there any RCTs of patients in category of diseases for prehab versus not, or
there are, but I think they're pretty small as
Yeah.
far as I know.
There's a big upfront investment, but if you're either avoiding surgery on someone who isn't going to do well,
Right.
or preventing post-op complications in nursing home, then it's probably worth it.
Yeah. A lot of times these rehab programs are sort of bundled into the CERAS programs, the programs. So it's sort of a prehab, not just including like the PT beforehand, the nutritional optimization and all of those things before surgery, but they actually do a lot of patient education. So if they think because of XYZ of your medical history and what surgery you're having, you're likely to end up at a SAR, they start talking to you before you have surgery, like which SARs do you want to go to? Would you want to visit before you have your surgery and see which so they're doing a lot of this really advanced discharge planning to figure out sort of so patients know their options. So they're not hospital, post-op day 2 and suddenly oh, guess what, you have to go to SAR, and the patient's I don't want to go, it's all sort of bundled into sort of these way to look at the patient before they have the surgery so that expectations are well managed and the patient's families can prepare and makes just everything a lot easier. But some of that stuff is all bundled into these programs. So again, a lot more to come about this. And again, unclear whether these interventions will really impact outcomes. but I think it's an interesting topic to talk about and keep talking about, and I think that at least on sort of like a preliminary level, I mean, just opening the lines of communication with patients, families, the surgeon, and PCPs, and sort of making sure everybody's sort of on the same page before these patients go for these surgeries when we know that they're frail and have a high potential not to do well is a place to start. We're really going to switch gears to a little bit again and talk a little bit more about pre-op risk calculators, which everybody loves the RCI, and it's everybody's favorite risk calculator, but we can talk about a couple of the other ones a little bit more. Okay. So this is like the crux of this flowchart, right? So we want to talk about, estimating the risk based on like the combined clinical and surgical risk. We like basically universally use the RCRI. I don't know if anybody ever really uses any of the other risk calculators. Does anybody use them regularly in their practice? Try to use this book. I don't use them all that often, but once in a while, I think they're a little helpful. So this was a comparison of 4 cardiac risk calculators in predicting post-op cardiac complication after non-cardiac surgery. This was done by Stephen Cohn, who's like one of the gurus of pre-op medicine. It was basically a retrospective chart review that they did in their pre-op assessment center. And they compared, they basically retrospectively calculated these 4 risk scores for these 600 patients who came into their clinic. Just basically chart digging. So I'll talk about 3 of these and compare them a little bit. So RCRI is the one we're most familiar with. RCRI is based on data from like 1989 to 1994. It was collected. I think the original study was published in 99. So data is old. It was derived from a group of like over 4,000 patients, all from a single institution, so just one hospital. They just looked at patients who were over 50 years old, patients going for non-emergent, non-cardiac surgery with an expected length of stay of more than 2 days. Again, we all know the risk factors. They looked at 6 different risk factors for surgery. The outcomes they looked at, I think we also are familiar with, so MI, pulmonary edema, VFib, cardiac arrest, or heart block. And they only looked at the time frame for these events was in the hospital. So whether the length of stay was just 3 days, they're only looking at the actual next hospitalization. The MICA score and the other one that you guys are talking about, the NISPA, is probably the one that I've shown you in the past, which is the American College of Surgeons Surgical Risk Calculator, which is the one all the way on the right. Both of those are actually based on NISPA data. Again, so these are huge databases looking at like hundreds of thousands of patients. This one is like over 1 million patients. They looked at all patients over the age of 16. These are looking, so the MICA score looks at 21 categories of surgeries. And anybody who's ever used the surgical risk calculator knows there's thousands of surgical risk categories in that one. It's based on CPT code, and it looks like at every surgery that there could ever be. So the MICA score is actually pretty easy, although you still do need like a computer or like a smartphone to use it. It's not something you can calculate on the fly, but it only looks at 5 different risk categories, and the surgical risk calculator looks at 21. So a big difference there. Again, the outcomes are MI cardiac arrest only, and they're looking at 30-day outcomes. So we'll come back to this in a minute. But so the RCRI we all are very familiar with. The risk factors are the surgical risk itself, the ischemic heart disease, congestive heart failure, cerebrovascular disease, chronic renal insufficiency with a creatinine greater than 2, and then diabetes on insulin. There was a reconstructed RCRI that came out in 2013, which I think never really caught on because it didn't really perform any better than the original RCRI, but just so you guys are sort of aware what it is. It's very, very, very similar. For renal insufficiency, they changed it to GFR base, so less than 30. And the diabetes they actually found was like not necessary and didn't help improve the accuracy of the calculator. I only mention it because it's one of the ones they talked about in this study. So the RCRI, just in general, I think we're mostly familiar with the advantages. It's very simple and easy to use. It's very widely used. It's sort of considered the gold standard for pre-op assessment. It does a very decent job at separating low and high-risk patients, and it's been externally validated many, 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 many times. Again, this data is like 20 years old at this point. The disadvantages are kind of a lot, though. So it underestimates the risk in vascular surgery patients, of which we see a lot. Again, it's based on 25-year-old data from a single institution. The outcomes they used for MI and things like that, they were using CKMB at that time, so it probably was missing some things. They didn't have troponin, so they were missing probably some, demand ischemia kind of and SEMIs. Again, these broad risk categories, low, medium, and high risk surgery. There really was not endovascular, vascular surgery options at that time, and they didn't really talk about, there wasn't laparoscopic surgery, it wasn't widely used at that time, so it's not incorporated sort of into that data set. There's no assessment of functional capacity. It's generally not a great predictor of all-cause mortality, and it tends to overestimate the risk in patients undergoing low-risk surgery and patients who have a expected length of stay of less than 2 days. So we're overestimating the risk in our lowest risk patients. This is the MICA calculator, the Gupta periop risk for myocardial infarction or cardiac arrest, MICA. This is on easily Googleable and easy to get on your phone or computer. So just for comparison, it sort of looks at age of the patient, functional status, which I think is interesting given the concept of all the frailty stuff we were just talking about, because these two calculators do incorporate some level of functional assessment. So whether the patient is independent, partially dependent, or totally dependent. This includes ASA class, which we're all very familiar with, but sort of is pretty subjective. Creatinine is in this one, and then the type of surgery. And again, these are sort of general categories. So this is he's going for a cholecystectomy. The category is gallbladder, appendix, adrenals, or spleen. So sort of surgical categories. So this patient, 70 years old, hypertension, diabetes, CAD with a good exercise tolerance, calculates up to 0.6% risk of MI or cardiac arrest for up to 30 days. So this guy who CAD, diabetes on insulin would really be elevated risk, again, by RCRI score, but he's pretty low risk by this calculator. So the MICA score advantages, it's better predictive ability than the RCRI, and it's more surgery-specific risk than the RCRI. It's got the categories versus 3 categories. Again, NISQIP lacks a lot of data, so it doesn't necessarily always, incorporate whether a patient has these prior histories of CVD. Again, it may miss NSTEMIs, which is a big issue generally with kind of post-op management of a lot of these patients. And again, you need the smartphone or the computer to calculate it.
Can I ask a question? I feel like in clinic we're often talking about someone, is there an ASA 2 or 3?
Mm-hmm.
We have a side reason to be asking that, who needs to see them. But
Right.
does that, say somebody called someone a 2 instead of a 3, would it change their risk a lot? Since that's a little bit subjective.
It's definitely subjective. I haven't played around with it enough to I didn't play around with it that much for this messing with it that much. I think I did change it at one point when doing this, but for such a low risk overall, I think it went from 0.4 to 0.6 kind of thing, so it did change it a little bit, but it wasn't like enough to make a tremendous difference. I don't think it would make you go from like 0.6 to like 2.5 or something like that. That might make a big difference.
I've used it a fair bit. I used to but it doesn't make a difference. Play around with like the functional stats part, and that one makes it makes this so it does actually.
Have you like noticed that with ASA2 versus 3 though?
I think so, but it's more, and also it's like the surgery type also. So like certain categories like spinal surgery, like it changes a lot more dramatically, but things like holy, like this functional status doesn't really change that much. So that's another surgery as well.
So again, I think you guys have seen this before, but this is the surgical risk calculator. Again, a lot of different categories in this one. It looks at like, again, functional status, talks about whether ASA class is in here too, whether the case is like emergency versus not. This incorporates other things like ascites, sepsis, ventilator dependent, cancer, smoking. So this is like a lot of different things. It's a lot more complicated, obviously. You have to have a lot more information about the patient, although hopefully we have most of this information when we're doing a pre-op assessment. It's just slower and harder sort of to. And like it actually, even though this includes a lot more clinical information about the patient, it like really actually performs like almost the same as this one, which is much simpler. The nicest thing about this one though is this at the end result, which is that this is like a nice tool that you get, which can be really helpful, especially I always think it's more helpful for patients who by like RCRI, they really don't have any like cardiac risk factors. I'm not really worried about a cardiac complication for the patient, but I'm worried about pulmonary complications or renal failure or other things that I think is what elevates this patient's risk. It does talk sort of at the bottom about like the risk of mortality, but it also talks to discharge about risk for discharge to a nursing home or a rehab facility. So again, if you're thinking sort of along that like bariatric frailty like line of thought, like I think some of these tools are a little bit more helpful and do incorporate that functional status of the patient and sort of ultimately what their outcome might be, not just one mortality or like a MACE, but just sort of overall how are they going to do. So again, this one includes like all these surgeries. There is something at the bottom where like, I don't think it's on here, but there is something where the surgeon can actually sort of like adjust. Like there's like a question that sort of says like, do you think this patient is like a higher risk than average sort of thing question. And then this also includes this question of like whether there's other surgical options. So like if this is like the only choice for this patient, like it factors into the ultimate outcome versus like whether this patient could maybe get by with like XRT or something like that. So there's a lot more that goes into it. Again, it provides this like nice visual tool, which can be helpful for patients and families and things like that when you're discussing risk and informed consent. So it's complicated, requires a lot of data, you need a computer. There are some subgroups in which it doesn't perform as well. So major head and neck surgeries, gynec surgeries for some reason, and breast reconstruction are all like categories of surgeries where it hasn't performed quite as well as it does generally across the board. It tends to overestimate the risk in low-risk patients and high-risk patients and underestimate the risk in moderate-risk patients. So it's actually being recalibrated, I think, based on like more use and like to kind of even that out and make it a little bit more accurate. This is like just a summary slide looking at all of these different categories, RCRI and reconstructed RCRI on the left. And like I can just sort of see like just on the right how complicated that surgical risk calculator is by comparison to the other ones. So in this trial or this study, they again they calculated these 4 different calculators for all these patients. So it's like 600 patients. 93 to 98% of the patients were actually classified as low risk using these calculators, depending on which one they used, which just struck me as being so different than the population we see on GP2. I feel like we see most of our patients are somewhat elevated risk, or at least I guess the ones that we see. I guess the lowest risk ones are often not seen by us at all. They just see PAs, but just in general, I feel like we see some of the sickest patients going for surgery, and it sounds like the kind of clinic who sees all comers. So the 4 calculators performed actually pretty well, all pretty similar actually, especially for identifying the lowest risk patients. So if the patient was low risk, it really didn't seem to matter too much which calculator you used, and the patient fell into the low risk category, the rates of MACE for all of those patients was less than 1%. The RCRI and the reconstructed RCRI basically performed equally well to each other, which is what we expect just based on the validation studies for the reconstructed RCRI. And then the MICA score, at least in this trial, performed a little bit better than the surgical risk calculator at identifying those like highest risk patients. So in general, all the calculators performed equally well at identifying low-risk patients. Just to keep in mind about the RCRI, it doesn't perform well when you use it differently than it was intended to do. So again, it's looking at like all of those cardiac complications, like including pulmonary edema, DTAC. So not just looking at MI and mortality like the other ones. So if you're looking to only talk about the major cardiac complications, or if you're trying to look at events going out to 30 days, it wasn't designed to do that. It's only looking at like the index hospitalization, and like you have to look at sort of like all comers in terms of the cardiac complications. Otherwise, it's just not as good at predicting. And I would think about using the MICA score or the surgical risk calculator for those low risk, for the patients undergoing low risk procedures and with an expected length of stay in the hospital of less than 2 days, because the RCRI tends to overestimate the risk in that subcategory of patients. RCRI also tends to underestimate the risk for the vascular patients, so you also might want to try to use different calculators for the vascular. I mean, I think RCRI is like still sort of the one that institutionally we like are the most familiar with. I mean, the other nice thing about the RCRI that I sort of didn't mention is that not only does everybody have a lot of experience with it and it's easy to use in general, but it's also because everybody knows how to use it, it's easy to look at the RCRI score at a glance and like sort of have a sense of what patient you're talking about, right? Like if the RCRI is 1 versus 4, we all have a sense of what that means. And that's across the board, right? Surgeons know what it means, anesthesiologists know what it means, so it's all nice. I don't know that I would stop calculating the RCRI, but I feel like if your RCRI doesn't feel like quite fits based on like your clinical results, or if you really think the patient has like a low cardiac risk but high risk in other categories, I might consider using the other calculators. Because RCRI again doesn't take into any functional capacity, so if the patient is really, really debilitated, but again their RCRI indicates their low risk, I might try to use the MICA for that. That's incorporate functional status, so that you might have a very different score in that situation. It's kind of like adding on a bonus, but I wouldn't necessarily stop the RCRI if that answers your question. Okay. Points. It's okay to hold aspirin in vascular surgery patients unless our vascular surgeons here tell you not to. ACE inhibitors do cause more intra-hypotension, and the jury is still out about whether this is actually associated with major adverse cardiac events or increased mortality. Frailty is a major surgical risk factor for elderly patients, and we should start thinking about assessing that in a more robust way. And I would think about using the MICA or the surgical risk calculator for patients going for low risk procedures with a length of stay of less than 2 days.
Thank you.
Thank you.